short presentation. I will be back. Meanwhile, I call upon Dr. Sumitha Muthu to give her presentation on myopia control contact lenses.
Thank you, Dr. Nina and Dr. Remya, for the kind invitation. It's a pleasure to be talking about myopia control contact lenses, because we've been working with these lenses for almost 4 to 5 years now. So I have no financial interest in these lenses. So I'll just begin with the typical case scenario that we commonly come across. First presentation was at 8 years. Current age is about 13.6 years. And you can see this is the kind of progression that the child had. We had introduced atropine quite early. But you see that despite atropine, there is a progression here. Okay, so it is in such case scenarios that we have to look for another treatment. So what do we do when a particular treatment fails? For example, the spectacle lenses or atropine, when it fails, that is when we consider the ortho-K lenses. So these are the typical risk factors that we look at whenever a child shows progression or whenever a child presents with myopia. First is the parental myopia, second is the outdoor time and the near activities. So this particular child had one parent with myopia, and outdoor time and near activities were all supporting faster progression. So we tried to reverse those. Despite that, the child showed progression. That is when we introduced the ortho-K lenses. And you can see over here that, sorry. So you can see over here, the circled area shows the control of the axial length. You can see that there is almost no progression in axial length. In the initial years when we were using the ortho-K lenses, we used to stop the ortho-K lens, give a washout period for about 2 to 3 weeks, reassess the refractive error to see if there is any progression. But I have learned in the recent times that you don't need to monitor the refractive error. You can just monitor the axial length, that is more than sufficient. So we do not give any washout period. We only record the axial length and perform dilated fundus evaluation on a routine basis and do over refraction on a routine basis to see if there is any progression. So I think Dr. Nina already spoke about how these lenses correct the peripheral hyperopic defocus. Ortho-K works also the same way that DIMS does. What it does is the contact lenses actually the contact lenses actually push the surface of the cornea, and then it thins out the central part of the cornea, the epithelium thins out, and in the periphery, the epithelium thickens. So this is how the ortho-K lenses work. So what are the indications for ortho-K? I think I've already discussed where there's a significant myopia progression. The first speaker already told us about what is significant myopia progression, anything more than 0.5 diopter. You can also consider it in children who are very, very active, for example, in sports, swimming, or they may be dancers. They do not want to wear spectacle lenses, and they do not want the hassle of wearing a contact lens and having some dust in the eye, etc. So again, in such children, it is an excellent option. What we have been doing is we have been considering these lenses in children who progress despite a myopia control strategy. For example, with atropine, they're progressing and they're progressing rapidly. Or with DIMS glasses or with Hall glasses, if they're progressing, that's when we consider these ortho-K lenses. And also in certain children who are non-compliant, especially when it comes to atropine eye drops. So selection criteria for in our practice, it was at least the child has to be about 7 years. The youngest child that we have is about 8 years old, who's on ortho-K lenses. Again, the child has to be very compliant. The refractive error that it can correct is up to 10 diopter of sphere and up to 2 diopter of cylinder in case of normal ortho-K lenses, whereas the toric ortho-K lenses can correct up to 3.5 cylinders. Of course, there should be no surface pathology like dryness, allergic eye disease. There should be no ectasia or no thinning of the cornea or no suspicion of any corneal pathology. So this is the basic evaluation that we usually do. We do a manifest refraction, we do a cycloplegic refraction. We take a baseline topography, a pentacam. We look at the horizontal visible iris diameter. This is very important when you first choose which ortho-K lenses to put on trial. These other factors also play a role, for example, pupil diameter, lid position, etc. So how do we determine which lens to start with? See, usually these ortho-K lenses, they give a trial set. The trial set is given by the company, and you train yourself, either a pediatric ophthalmologist or an optometrist does the ortho-K fitting. And for that, you need these following parameters. What is K code? It's the mean of the keratometry, the steep and the flat. The lens size is the overall diameter. This is about 93 to 97% of the horizontal visible iris diameter. This is simple. You can simply obtain this by calculating the wide to wide diameter on the pentacam. Then you also have the power code, which is the spherical error plus the astigmatism from the topography divided by 2. So this is how you calculate the lens size. By show of hands, may I know how many of you are already using ortho-K lenses? How many of you are interested in using ortho-K lenses? Okay, thank you. So, in which case I will talk about a few practical pearls, and then we will not go too much into detail about the lens fitting, because that won't be relevant when you're not already using. So HVID can be measured, as I already told you, using the HVI ruler. I'll just show you the ruler later. So this is the HVID ruler that we use to measure the size of the ortho-K lenses to be chosen. See, an ideal fit would be what you see centrally. That's called the bullseye pattern, where you see a flat cornea, no staining in the center, and then you see a periphery ring with staining, and then again a peripheral ring with no staining. This is called a bullseye pattern, and this is the ideal fit that you should be aiming for. So again, what we do is, once you choose a particular lens based on these parameters, you put the lens on, you do fluorescein staining and look for the bullseye pattern. Okay, the patient has to put these lenses on and close the eyes for 1 hour. So remember that ortho-K lenses are night wear contact lenses that the patient has to wear and sleep with. The lid compresses on the contact lenses and then causes all of those changes, epithelial changes that I previously spoke about. Okay, and then after this 1 hour period, you repeat the pentacam to see how much flattening you have achieved. You also do a fluorescein staining to see how much flattening you have achieved and see if the fit is ideal or not. So an ideal fit would be this. Okay, you can see a good bullseye pattern, and this is how the pentacam would be when you repeat it after putting the ortho-K. So whenever there is an improper fit, you have to do some troubleshooting and see if there is a flat fit or a steep fit. So see, here you can see there is a flat fit. You can see there is too much staining, there is poor seal off, you can see there is stain even in the peripheral ring where there should not be any stain. And you see a smiley face topography like this. When there is a steep fit, this is what you see. I think we'll skip the fitting parameters and just go to our experience with ortho-K. We advise ortho-K for about 34 patients, out of which only about 28 patients cross the 1 year follow-up period. And therefore, we analyzed these patients, and the mean follow-up was about 29 months. And what we saw was that in these patients, the axial length increased at a very minimum rate of 0.07 millimeter per year, which is, of course, statistically significant, but not clinically significant. And only 2 patients had contact lens related complications like punctate epithelial erosions and SPKs. So this is what we saw in 2 patients, and most other patients did not have any complications. There are various other multifocal contact lenses that are available which mimic the ortho-K lenses, but they are not as effective. I have personally used some soft contact lenses, but we found that this kind of axial length control and refractive error progression control we have not achieved with these kind of lenses. These are the other soft lenses which are available. So, so my message would be that ortho-K lenses is definitely a good option for treatment failure. It is preferable in certain demographics like sports people. Like we have a lot of patients who are active in sports like cricketers or footballers who are actually on ortho-K. And of course, it has a learning curve, but it is not very steep. Once you know your topography, ortho-K fitting is made very easy. And the chances of vision-threatening complications, remember, are far less. If you have fear of contact lenses in children, these vision-threatening complications are far less than the actual complications of high myopia. So definitely use this option, and these are easily treatable complications, so we need not worry at all. Okay, thank you for the opportunity. If there are any questions, we can take it up later.